Welcome back to another Clarity Education Systems live session. I'm Dr. John Rossi, and I'm excited to have you here with us as we continue to work towards understanding and learning high-yield PMHNP content to get you ready for your exam. These sessions are designed to challenge your thinking, reinforce critical concepts, and sharpen your test-taking skills, all with the goal of helping you pass your PMHNP certification exam with confidence. Now, in our weekly sessions for students in the Clarity Education program, we'll go through test-taking strategies each week to help you identify the best way to answer these questions. So, whether you're here to fine-tune your knowledge, build confidence, or just to get some extra practice, you're in the right place. So grab your notes, get focused, and let's dive into our first clinical question. All right, here we go. So today, let's start this session with a case that highlights the impact of polypharmacy on cognitive function. When managing patients with multiple chronic conditions, it's crucial to recognize how medications interact and contribute to neuropsychiatric symptoms. The question reads, a 62-year-old patient with a history of MDD, hypertension, type 2 diabetes, and chronic pain presents with worsening cognitive difficulties, excessive fatigue, emotional blunting, and intermittent confusion. He is currently prescribed duloxetine or Cymbalta, metoprolol, insulin, gabapentin, and tramadol. The patient reports that his symptoms have progressively worsened over the past few months, and his family is concerned about increased forgetfulness and reduced engagement in daily activities. The PMHNP questions the patient's mental health symptoms. Which of the following is the most appropriate approach to optimize medication management in collaboration with other healthcare providers? So, quick side note, I bet you're kind of stressed about the length of this question and also the answers. In this session, I really wanted to help you focus on how long these questions may actually be. This is not uncommon in the certification exam, so you want to start practicing lengthy questions. All right, on to the answer choices. So A, conduct a comprehensive medication review, assess pharmacokinetic interactions, and consult with prescribing providers to determine if prescribing, deprescribing, or dose adjustments are necessary. B, recommend continuing or discontinuing the patient's duloxetine, Cymbalta, as it may be contributing to the cognitive impairment and fatigue, and then initiate a different antidepressant with fewer sedative effects. C, order neuroimaging and a full dementia workup before making any medication adjustments to rule out an underlying neurodegenerative disorder. Or D, suggest adding a stimulant, such as modafinil, to counteract the patient's fatigue and improve cognitive functioning while maintaining their current medication regimen. All right, so think about the role of polypharmacy here. Several of these patients' medications have CNS depressant effects, and the symptoms may be medication-induced rather than due to primary neurocognitive decline. So what's the most appropriate first step? Okay, if you selected A, right on, you're absolutely correct. Let's break it down. So polypharmacy is one of the most common and reversible causes of cognitive impairment in older adults. So the key risks in this for this patient, so we have tramadol and gabapentin. Both have CNS depressant effects, contributing to fatigue and cognitive slowing. Then we have duloxetine, which causes sedation, but is unlikely to be the primary issue without considering drug interactions. Metoprolol, this can lead to fatigue and dizziness, which may worsen cognitive complaints. And then multiple interacting medications, this is going to increase the risk of synergistic CNS depression. The best approach is going to be to conduct a medication review, assess for cumulative side effects, and collaborate with other prescribing providers to determine whether deprescribing or dose adjustments would reduce cognitive impairment without compromising symptom control. Now let's review why the other options weren't the best choices. So first we have B. While duloxetine can cause sedation, abruptly stopping without reviewing other medications is going to be premature. Plus, stopping duloxetine suddenly can trigger withdrawal symptoms, so worsening the patient's condition. This is called discontinuation syndrome. Option C. So while dementia is a consideration here, medication-induced cognitive impairment is more likely a reversible cause. So addressing polypharmacy first can help differentiate between medication effects and a true neurocognitive disorder. And option D, adding a stimulant. So introducing modafinil or other stimulants without adjusting medications could increase cardiovascular risk and worsen drug interactions. Without addressing the underlying issue, polypharmacy should be optimized before adding any additional medications. So the key takeaway here, polypharmacy can equate to common causes of reversible cognitive impairment. This case is a great reminder that medication side effects can mimic neurocognitive disorders. But the good news is they're often reversible with careful deprescribing. So always assess polypharmacy in older adults with cognitive complaints. Deprescribing and dose adjustments are more beneficial than adding medications, and then collaboration with other providers ensures that medication changes are safe and effective. So by recognizing and managing medication-related cognitive impairment, we can improve patient outcomes while minimizing unnecessary interventions. All right, great job with that one. Let's go ahead and move on to the next clinical question. So let's explore a case that highlights complex relationships between trauma and dissociative symptoms. Dissociation can manifest in many different ways, from memory lapses to feeling detached from one's body. So accurate assessment is going to be key to making the right diagnosis. The question reads, a 34-year-old patient with a history of childhood trauma presents to the psychiatric clinic with complaints of feeling disconnected from reality, memory lapses, and episodes of losing time. The patient describes periods where they find themselves in unfamiliar locations without recollection of how they arrived there. They also report feeling emotionally numb, detached from their body, and experiencing an eerie sense of watching themselves from a distance. On further questioning, they reveal a history of flashbacks, nightmares, and avoidance behaviors related to past trauma. Given these symptoms, what is the most appropriate next step? So our answers include A, administer the Dissociative Experiences Scale, or the DES, and conduct a structured clinical interview focusing on the presence of dissociative amnesia, depersonalization, and identity fragmentation. B, evaluate for PTSD using the clinician-administered PTSD scale, or CAPS, and assess the severity of dissociative symptoms within the context of trauma-related stress diagnosis. Let's go back to C. So conduct neuroimaging and neurocognitive testing to rule out any organic causes such as temporal lobe epilepsy or structural brain abnormalities before confirming a psychiatric diagnosis. Or D, begin a trial of an SSRI to target underlying trauma-related anxiety and mood symptoms, as dissociation often coexists with affective dysregulation. So this case presents multiple dissociative symptoms, right? Including memory lapses, depersonalization, and time loss, all commonly associated with dissociative disorders. What is the best first step in making an accurate diagnosis? Okay, if you selected A, great job, you nailed it. Let's go over why this is the best choice. So dissociative disorders are characterized by disruptions in memory, identity, and perception of reality. In this case, the patient is experiencing 1, dissociative amnesia, episodes of losing time or finding themselves in unfamiliar locations. Depersonalization, when he or she is feeling detached from their body as if they're watching themselves from a distance. And then 3, we have emotional numbing and trauma history, strongly linked to dissociation as a coping mechanism. So what's the best next step then? So the Dissociative Experiences Scale, or the DES, this is a validated screening tool for dissociative symptoms. A structured clinical interview is going to help differentiate between dissociative amnesia or memory gaps related to that trauma, depersonalization or derealization disorder, feeling detached from self or reality, And then finally, dissociative identity disorder, also known as DID, this is formerly multiple personality disorder, to identify fragmentation in multiple distinct personality states. So since dissociative disorders often emerge as maladaptive coping mechanisms in response to severe trauma, a detailed trauma history is crucial. All right, so let's take a closer look at why the other answers aren't your first steps or best step options. Okay, so option B, evaluating for PTSD using CAPS. So while PTSD and dissociative symptoms often co-occur, PTSD-focused assessments like CAPS may not distinguish dissociation as a primary disorder. The patient's episodes of losing time and depersonalization suggest this primary dissociative disorder, requiring specific tools like the DES and structured interviewing. Option C, so while organic causes like temporal lobe epilepsy should always be considered, this patient's history is strongly trauma-related. Unless there's a neurological red flag like a seizure-like activity or motor deficits, psychiatric assessments should always come first. And then option D, starting an SSRI immediately. Now, SSRIs can help with comorbid mood and anxiety symptoms. They do not directly target dissociation. Diagnostic clarity should be established first before initiating pharmacological treatment. All right, so the key takeaway here, dissociative disorders is going to equal memory disruptions plus identity disruptions plus depersonalization. In this case, it reminds us that dissociative symptoms can be mistaken for other psychiatric conditions, including PTSD and psychotic disorders. So you want to use Dissociative Experience Scale, or the DES, as that screening tool. You want to conduct a structured interview to differentiate between dissociative disorders and then understand the link between trauma and dissociation, because it's often a coping mechanism in response to overwhelming stress. So by recognizing dissociative symptoms early, we can ensure accurate diagnosis and provide trauma-informed care that truly helps the patient heal. All right, we're going to go ahead and move on to our third clinical question here. And we're going to discuss a case that highlights really one of the biggest challenges in psychiatric care, and that's treatment-resistant acute mania. So patients experiencing mania with grandiose delusions often lacked insight into their condition, and this is going to make engagement difficult but essential. The question reads, a 38-year-old patient with bipolar I disorder is brought to the emergency department by family due to increasing erratic behavior, decreased need for sleep, excessive spending, and grandiose delusions about being a world-renowned scientist with a, quote, mission to cure all diseases, close quote. The patient refuses medication, denies any psychiatric illness, and insists that treatment is unnecessary. They state, I don't need your help. In fact, I should be helping you all. Attempts to engage them in discussion about their condition results in hostility and accusations of being persecuted by the medical establishment. Given the patient's lack of insight and treatment refusal, what is the most effective strategy for engaging them in promoting treatment adherence? And our answers are: A, utilize reality testing and logical reasoning to challenge the patient's delusional beliefs and emphasize the necessity of medication. B, establish rapport by aligning with the patient's perspective and then gradually guiding them towards treatment acceptance. C, invoke emergency involuntary hospitalization and administer treatment over the patient's objections in order to prevent deterioration. Or D, allow the patient to leave against medical advice since they are not expressing intent to harm themselves or others. So this patient presents with those classic manic symptoms, including grandiosity, decreased need for sleep, excessive spending, and treatment refusal. The key question is, how do we engage someone who doesn't believe they need help? Okay, if you chose B, you're spot on here. Let's break it down. So engaging in manic patients requires building trust first. Patients with agnosia or this lack of insight, they are unlikely to accept direct confrontation about their condition. Instead, we use motivational interviewing techniques to foster collaboration. First, you want to find common ground. I see that you're passionate about your mission. Let's make sure you're at the best so you can achieve it. Avoid direct confrontation, so challenging their beliefs makes them defensive and escalates agitation. 3, we want to emphasize function over illness. So rather than forcing acknowledgement of their diagnosis, focus on how treatment can help them reach their goals. So this approach is especially useful for manic patients with grandiosity, paranoid or treatment-resistant individuals, and then patients refusing medication due to lack of insight. All right, so let's go over why the other options weren't the best first approach. So we have option A, challenging delusions with logic. Directly arguing against delusions, it just doesn't work. These beliefs are fixed and they're resistant to reasoning. Instead, patients may see providers as adversaries, increasing paranoia and resistance to treatment. Option C, immediate involuntary hospitalization. So forced hospitalization is always a last resort. Remember, we take the least invasive approach first. And while sometimes it is necessary if the patient is at imminent risk to themselves or to others, premature coercion can worsen distrust in the mental health system, and it's going to make further engagement even harder. And then option D, allowing the patient to leave AMA. While the patient is not exactly violent, mania impairs judgment, putting them at risk for financial ruin because of reckless spending, dangerous impulsivity, risky behavior like excessive travel, high-risk investments, promiscuity, and relationship strain and legal consequences. So allowing them to leave without intervention could lead to significant harm. So our key takeaway here is therapeutic alliance is going to equate to key to engaging manic patients. Managing treatment refusal in mania is definitely a delicate balance. The goal is to engage rather than confront by aligning with their perspective, building trust, and gradually guiding them towards treatment. Remember, we want to avoid challenging delusions head-on. It increases resistance. We use MI, or motivational interviewing, to frame the treatment as a tool to help the patient achieve their goals. We want to prioritize rapport over coercion whenever it's possible. And then if necessary, then we use involuntary treatment only when the patient poses a serious risk. When working with manic patients, your approach matters just as much as your clinical knowledge. All right, so let's move on to our fourth clinical question here. So one of the biggest challenges in psychiatric evaluation is distinguishing substance-induced mood disorders from a primary psychiatric condition. Substance withdrawal can mimic major depressive disorder, making careful assessment essential before we go in and we initiate treatment. This question reads, a 45-year-old male with a history of severe alcohol use disorder and intermittent stimulant use presents to the psychiatric emergency department with complaints of profound anhedonia, emotional numbness, insomnia, and difficulty concentrating. He denies current alcohol or stimulant use and states, I feel like I'm sinking into a hole and I can't climb out. I don't know if this is withdrawal or if it's always been like this. The patient has no prior psychiatric history, but reports similar depressive episodes in the past, which he self-medicated with alcohol. His last use of alcohol was 5 days ago, and he has no signs of delirium tremens or acute withdrawal. What is the most appropriate next step in differentiating between substance-induced mood disorder and a primary mood disorder? Our answers include A. Initiate a benzodiazepine taper to mitigate withdrawal effects and reassess mood symptoms after 2 to 3 days or weeks. B. Conduct a longitudinal assessment of mood symptoms, including pre-substance use history, and delay pharmacologic treatment until withdrawal resolution. C. Start bupropion or Wellbutrin to target the patient's anhedonia and fatigue while minimizing the risk of emotional blunting. Or D. Obtain neuroimaging to assess for structural brain abnormalities that may explain mood dysfunction in a chronic substance user. Now, in this case, we see a diagnostic dilemma. Is this a primary mood disorder, or is it a substance-induced depressive state? What is the best approach for differentiating between the two? All right, so if you chose B, great job. Let's find out why. So substance-induced mood disorders can mimic primary mood disorders, but they often resolve once the substance clears the system. So this patient's history of alcohol use to self-medicate depressive symptoms raises the question: was the mood disorder present before the substance use, or is it withdrawal-related and temporary? So what is the best next step? We want to assess for pre-substance mood symptoms. This is finding out if the depression existed before alcohol use began. Then we want to assess delay in pharmacological intervention. Let withdrawal symptoms resolve before diagnosing that MDD. We want to monitor symptoms over several weeks. So if mood symptoms persist beyond 4 weeks, a primary mood disorder is more likely. Alcohol and stimulant withdrawal, it can cause anhedonia, emotional blunting, insomnia, fatigue, cognitive slowing, irritability, and dysphoria. Because these symptoms often improve as neurochemical hemostasis returns, premature antidepressant initiation can lead to overdiagnosis and overtreatment. Now let's take a look at the other choices. A, benzodiazepine taper. So while benzos are first-line treatment management for acute alcohol withdrawal, the patient, he's already 5 days post-cessation or post-stopping and has no signs of delirium tremens or autonomic instability. So benzodiazepines are unnecessary at this stage. Option C, starting bupropion immediately. Now, bupropion is effective for anhedonia and fatigue, but it lowers the seizure threshold, which is risky in a recently detoxed alcohol user. It also treats symptoms that may be temporary. So if withdrawal resolves, the patient may not need medication at all. And then option D, ordering neuroimaging. So neuroimaging, it's just not the first step unless the patient has some type of neurological deficit like weakness or ataxia. If he has cognitive impairment unrelated to the mood disorders or symptoms, and if there's a history of head trauma, then you would go with the neuroimaging. There's no indication of a structural brain pathology in this case, making that neuroimaging this low yield. All right, so distinguishing between substance-induced and primary mood disorders. The key takeaway: substance-induced mood disorders often improve as withdrawal resolves. So key takeaways here: assess for pre-substance mood symptoms. Was the depression present before the substances were used? We want to monitor symptoms over time. So if mood disturbances persist past 4 weeks, a primary diagnosis is more likely. And then we want to avoid premature antidepressant initiation. So treating withdrawal-related dysphoria can lead to overdiagnose and overtreatment. So by taking a more careful, longitudinal approach, we avoid this unnecessary medication and ensure accurate diagnosing. All right, moving on to our last clinical case question here. And this case highlights one of the most crucial responsibilities in psychiatric care: managing psychiatric emergencies, and then understanding when involuntary hospitalization is required for a patient and public safety. The question reads: a 27-year-old patient with schizophrenia presents to the emergency department reporting distress, auditory hallucinations, commanding them to harm themselves and others. The patient states, "The voices won't stop telling me to do it, and I don't know how much longer I can resist." They appear agitated and paranoid, and their insight into their condition is limited. What is the priority intervention, and what legal considerations must be addressed in this situation? Answers include: A, increase the patient's antipsychotic medication dosage and schedule a follow-up appointment within the next 48 hours. B, initiate voluntary hospitalization if the patient agrees to the treatment and then ensure close outpatient follow-up. C, place the patient on an involuntary psychiatric hold for immediate stabilization and risk management. Or D, encourage the patient to use coping skills and support systems while monitoring their condition in an outpatient setting. So this patient is experiencing command auditory hallucinations, directing them to harm themselves and others. The key question here is, what is the safest and most legally appropriate action? Okay, if you chose C, spot on, safest and the most legal approach here. So if you chose C, you're really looking at the psychiatric emergency from the right perspective. And this is where the patient has command hallucinations, harm themselves and others, has limited insight into their condition, and expresses unnecessity about resisting the voices, or uncertainty, excuse me. So immediate priority, what are we going to do? Ensure the safety of the patient and the public. We want to place the patient on an involuntary psychiatric hold, in most cases, for example, like a 72-hour hold. Again, this is going to be based on state law, though. And then we want to initiate stabilization with inpatient treatment. Some of the legal considerations we have to look at. Involuntary hospitalization is legally justified when the patient poses a danger to themselves, so something like suicidal ideation or a significant self-harm risk, poses a danger to others, homicidal ideation or some type of violent behavior, is gravely disabled, so unable to care for their basic needs due to a psychiatric condition. This patient meets the criteria for immediate hospitalization because of the risk of imminent harm and limited ability to resist the hallucinations. Okay, let's review those other options real quick just so we understand why they wouldn't be the best approach. So for A, when we adjust the antipsychotic treatment, it's going to be important, but it's not sufficient in a crisis where there's a clear risk of imminent harm. This patient needs immediate intervention and not delayed. Option B, so if the patient agreed to voluntary hospitalization, this would obviously be preferred. However, their limited insight and high-risk presentation is going to suggest refusal of care. So involuntary hospitalization is going to be necessary for the safety concerns. And then option D, encouraging coping skills and outpatient treatment or monitoring. So this patient is actively struggling with violent command hallucinations. Outpatient management is not appropriate in this scenario. And then allowing them to leave could lead to suicide attempt or self-injury, homicidal behavior, legal consequences for failure to hospitalize a high-risk patient. So this would be a serious misjudgment in risk management. So key takeaway here, involuntary hospitalization equates to necessary for imminent risk of harm. This case reinforces a critical principle in psychiatric care. When a patient is in imminent danger, hospitalization is mandatory, even if they refuse treatment. Involuntary hospitalization is appropriate when a patient is a danger to themselves or others, when command hallucinations and impaired insight significantly increase the risk, and legal criteria for psychiatric holds vary by state. So risk of imminent harm it's not a universal standard across the board. So you want to make sure with your state board of nursing or other legal entity in your state that you understand what your requirements are and for how long. So as mental health providers, we have both a clinical and a legal responsibility to act in the best interests of the patient's safety. All right, so great job tackling all these difficult cases. So let's wrap up today's session. You did great work. We're studying lots of really long questions here, so I know it can get taxing and exhausting, but this is what it's going to be like on the exam certification day, so you want to make sure you practice well before. Okay, so now as we do every Wednesday night, this would be the time where we open up the floor to questions and comments from the students every week. So you have a live interactive circumstance where you can talk about things that's, troubling you, bothering you, successes, whatever it may be. Your questions are there. So this is your time to bring up things like your semester and coursework, topics for the Clarity Review Program, concepts on your studies, practice questions you've struggled with, or anything else that's on your mind. So this exclusive live Q&A, it's going to be available via the PMHNP student portal for currently enrolled students. You want to click the link to join the discussion on the main page, and I look forward to answering any questions that you have. It's a really great time to come together and interact. Now, before we close out, I want to leave you with a couple of powerful reminders as you continue your journey toward becoming a PMHNP. So, the best revenge is massive success, and this is by Frank Sinatra. This is a reminder that your success is the best response to every challenge you faced. Every late night of studying, every tough exam, every setback. They don't define you. What defines you is how you push forward, stay committed, and prove to yourself that you can achieve this. Keep showing up, keep doing the work, and let your success speak for itself. And then finally, from Farah Gray, build on your own dreams, or someone else will hire you to build theirs. This quote hits home because it reminds us that you are in control of your future. You don't come this far just to help build someone else's dream. You're here to build your own. Every effort you make now is an investment into yourself, your career, your impact on mental health, and the patients who will count on you on day one. So stay focused on your dream, take ownership of your path, and never let doubt or fear hold you back. You're on the right path, and I couldn't be more proud of the dedication that you're showing each week. I'll see you next Wednesday at 7 p.m. Mountain Standard Time for another live session, and we'll see you out there in the live conferences or in the on-demand platform at the student portal. Until then, stay focused, stay determined, and keep moving forward. Bye-bye.